It's very complicated, and it didn't used to be so. What's really changed is our approach to how we assess a patient for what therapy. It used to be really one size fits all. If you were fit for induction, you got induction. If you were unfit for induction, we used something lower intensity, typically a hypomethylating agent or low-dose cytarabine, more commonly a hypomethylating agent, honestly. Or just supportive care alone if patients were not really fit for any therapy. Nowadays, we're not making these decisions based on just fitness. We're actually looking at the genetic complement of the leukemia. And we might still use fitness to say intensive versus low intensity therapy, but once we make a decision like that, particularly for patients looking at intensive therapy, it really makes a difference. As I said before, we know that using different induction strategy can improve survival. And that's true not just for patients with therapy-related leukemias or myelodysplastic syndrome-related leukemias, but it also looks to be the case for FLT3 mutated AML, which is a third of patients. It's true for core binding factor leukemias, which is probably about 15, maybe 20% of patients. And you start adding up those little slices of the pie, there's more and more patients that are getting a different approach than 7 and 3. It's no longer one size fits all therapy.